Hi everyone. I thought before I got kicked off with clinic today, I would give you all a little bit of an update from a research point of view. So welcome if you are a BPS nerd like me and you're interested in treating and understanding it. And if there's some patients listening, then this is not medical advice, this is just me having a look at what literature is available. So please make sure you're going to a health provider before you try and seek any treatment. Anyway, so I've got two papers and it's more to do with drugs. Now, from a physio perspective, we aren't prescribers, so we're not involved in the prescription of drugs, but it's really important that we understand the treatment that our patients are going through. So I thought I'd talk about two papers that are from 2017 that I've recently read and thought were quite interesting for different reasons, mostly to do with failure, which is great. I love a bit of failure. You've got to be a failure ninja, as my friend Jazz Ampalfar says. You've got to take failure and learn from it and grow from it. So I do a little bit of a lit review every now and then. I try to every 2 or 3 months, just to see what I've lost, what I've missed, and to make sure that we're all moving forward. The only way that we can be the best clinicians we can be is by knowing, trying to get as much knowledge as we can from everyone else. You know, there's no way that you, as a physio or a patient or whoever you are going to know everything about bladder pain syndrome. So it's important that we tap into those clever folks that know stuff that we don't. So, first of all, we've got Wang et al. From 2017, which was published in BMC Urology. I'll put the references below this somewhere. And it's about fulranumab, which I'm hoping I'm pronouncing correctly. But basically, this fulranumab is a type of drug called a nerve growth factor inhibitor, which we know that nerve growth factor is a component that's important in development of nerves and in the maintenance of pain states. Because if you think about the changes that we know at the level of the bladder that occur in bladder pain syndrome after a long period of time, we don't necessarily want lots and lots of extra nerves growing. We don't want to change the role of those nerves that are developing within the bladder. So there's a potential here that it could be a different form of pain relief, which is really exciting. And they talk a lot about the fact that there really isn't any good analgesia for bladder pain syndrome. So they did a randomised, double-blind, placebo-controlled, multi-centre trial, gold standard, to see if it provided pain relief. And they did lots of really cool stuff, but basically they took patients that were the most in pain. So people that had more than an 8 on an ICSI, your Interstitial Cystitis Symptom Index score. So they had really significant pain. They had to not have taken any drugs known to affect BPS, which for the physios out there that are interested, this is your list: antidepressants, histamines, spasmodics, cholinergics, and convulsants, or anticonvulsants, anticholinergics, antispasmodics, antihistamines, antidepressants. I'm not going to go into that now, that's a longer discussion, but if you're not aware of that, go look at it, it's really cool. So all these people are getting better over the summer because the weather is warmer. Maybe it's because they're taking their histamines. Anyway, or antihistamines. So they looked at, they actually only ended up taking 31 patients for a reason I'll tell you in a minute. But basically they found there was no difference between the groups. These people were injected 3 times over 12 weeks with fulranumab into their legs, and they looked at their average pain score. As in a little aside to those of us that are a bit geeky about numbers, they based their sample size on the assumed difference of 1.4 between the placebo and the treatment group. But 1.4 is not the known significant clinical difference point. So the point at which a clinically important difference is noted is 2 on that scale. So I'm not sure that basing it on a 1.4 difference between groups shows us anything, that there is a slight potential difference, but it's not, or significant difference, which isn't clinically important. Anyway, so a slight little niggly thing there. So they really wanted to look at whether they could use U-point, our phenotyping scale, or one of the phenotyping scales, to kind of look at who was best treated, if anyone got better pain relief from this. Again, we're always trying to find that way to best treat the patient, get the right patient, the right time, the right way. And it's a real shame they didn't get a chance to do that, because the FDA ceased all trials of fulranumab in 2010. And I know trials take a long time to come to publication, and I'm really happy that these guys published, even though there was possibly negative data or a negative press about it. And the reason the FDA stopped everything was because they had concerns about rapidly progressing osteoarthritis and osteonecrosis. So they ended up only enrolling 31 patients, and actually their data showed that there was no adverse events, no significant events, and no joint-related issues. And they followed them up for 2 years, those of them that were available, which I think was most of them. So quite an interesting one. It's a real shame because that had a little bit of hope as another form of pain relief or analgesia for our patients. But I thought it was quite interesting. So I'm hoping that, you know, something else comes out, that we get a bit more of a discussion about what it is about nerve growth factor injecting into people, anti-NGF, which causes these orthopedic symptoms, and whether they can tease that out, and whether then we might be able to put these trials back in and see if we can make a difference, which would be cool. The second one is Lim et al. From 2017, which is the long-term outcomes of intravesical dimethyl sulfoxide heparin hydrocortisone therapy for IC-BPS, which is basically what we know as DMSO, or a DMSO cocktail that they put into the bladder. So it's heparin, hydrocortisone, some other stuff that I'm not good at pronouncing, but it's meant to have an anti-inflammatory, muscle relaxing, which from a physio point of view, and if you understand BPS, great, and a bacteriostatic effect. I'm not really sure what a bacteriostatic effect is, but if someone could have explained to me, that would be cool. I've tried to look it up and it doesn't really make sense. Okay, and they also said that it would be better at transferring the other agents to the urothelium, so the bladder lining. So they gave these patients bladder instillations 2 times per week for 4 weeks, that's 8 times, and then weekly for 4 weeks. So they ended up with 12 installations over about 8 weeks. That's a huge amount of intervention. And they only followed them up if they needed it for 12 months. But they went on to review them for 2 years via phone. Interestingly, from a stats point of view, their age was around 44.8, okay, standard for BPS, somewhere in the middle age. BMI was quite normal. I'm not sure which group this was on. Where are they based? Australia. Fit Australians. Because their BMI was 26.2 average to maximum 28. Which is really healthy compared to our populations these days. And yeah, they followed them up for maximum 60 months. So they found, in general, an improvement, significant but modest, which is important, of 23 to 47% in their ICSI, which is our gold standard outcome measure. 23 to 47% improvement. Now, if we know that around about 20-25% is a placebo, which is real and is about the brain reducing the threat response in the bladder and dealing with it, and you kind of prompting that response through a holistic treatment, you know, understanding of treatment and feeling empowered and all that kind of stuff, that's useful. But that happens with most things if you do it well and you engage with the patient. So they've got another 20-25% on top of that of actual improvement, which is pretty important. More interestingly though, in uni and multivariate analyses, they found that failure was more likely, and this is key, in patients that had a pre-treatment nocturia of more than 2, so they're getting up more than twice a night. They had a reduced bladder capacity under anaesthesia of less than 500 or 400 mils, and the worse increased the risk. So if they had 400 mils versus 500 mils, it was they really weren't going to improve with this treatment. They had to have had a daytime frequency of more than 15, so going very often, and a max bladder diary volume void of 200 mils, so going to the toilet and passing very small amounts. Having a Hunner's ulcer, having glomerulations, your pain score weren't predictive of whether you'd fail or succeed with this treatment, which basically means that failure of a DMSO cocktail intravesically into the bladder is more common in patients with a smaller bladder capacity. That's interesting. That's really interesting. And actually may help us guide our patients a little bit more. So if we're dealing with a bit more of a truly stenotic bladder, potentially, I mean, they haven't really gone into the histopathology of it yet, whether it's when they have kind of glomerulations and Hunner's ulcers weren't limitations in this, weren't predictors. But whether we've got a stenotic bladder, whether we've got a little bit more scar tissue, what's going on pathophysiologically. My words aren't going well today. It's Friday. What's happening to create that really small stenotic bladder won't then respond to an intravesical treatment, so a treatment to the lining of the bladder. Whether or not that can change, if you give them physio first for 12 weeks and we train their bladder into a better compliance, we work with those bladder muscles to improve the bladder compliance. I wonder if that 47% or 25 to 30% improvement beyond placebo would be even more important. Who knows? So if you've got any comments, if you've got any questions, that kind of stuff, get in touch. I'll put the references down here, but I just thought that was interesting. So there is an update on some medico-pharmacal management of BPS.